Oh, yes, sir.
And
recording.
recording on करना.
Yes, sir. Recording started, sir.
No, I won't be sharing a screen right now. Later on.
Later on.
No.
Okay, sir. तो
अभी तो minimize करो.
आप दिखते रहेंगे सर अगर ये शेयरिंग होगी तो.
No, I don't need it right now. I just initially I'll just talk. Then just a minute. And one more thing is that कि तुम अपने phone से login करके then you start. You log in with your phone and take a thing. क्या बोलते? Attendance. You have to take a screenshot of the video.
सर ये अभी रिज्यूम शेयर करेंगे ना तब शेयरिंग चालू हो जाएगी. अभी शेयरिंग बंद है और ये सारे मेंबर्स हैं.
So can we sing it?
उसको एनलार्ज करो. अपने उसमें जाके सब क्लिक करेंगे एक डबल क्लिक. इसको ये वाला सर सबसे.
Hello, am I audible to everybody?
Yes, sir.
Yes. Should I start?
Yes, sir.
Resume the sharing answer. Where's resume sharing?
नीचे आप लाएंगे तो रिज्यूम शेयर पर दबाएंगे तो शेयरिंग चालू होगी.
अच्छा ठीक है. Okay. Okay. Good morning, everybody, or rather, let's say good afternoon, everybody. I hope all of you are currently in the mood of listening to a lecture. I think you just finished your gynecological session. So hopefully all of you are in a fresh mood. Now, today, we will consider a very common problem, which is varicose veins. Okay. And also it's a case which lot of students don't seem to understand at all. Now, number one, let us start off. I'm not, since we don't have cases, I'm not going too much into great detail. I mean, I cannot demonstrate a case of varicose veins, but I'll try my best to help you understand. Number one is what is a varicose veins. Now, varicose veins is a dilated and tortuous veins. In this case, it is of the lower limb, the ones we consider now, we consider lower limb, but it could be of other systems as well. It could be like you could have a varicocele of the spermatic vein. Then you could have what is called the hemorrhoidal veins. You could also have the esophageal varices, etc. But now in this condition, we will consider the veins of the lower extremity. So now, if you can you see my screen? Where is the screen sharing?
Resume share.
I pressed resume share, but then it was showing.
Yes, we are seeing the screen, sir.
Okay. Now, I want to go back. Yeah, but I want to the previous all pictures. Now, over here, this diagram I've drawn for your benefit. Here you have this. Now, again, in varicose veins, the most important vein which we consider is the great saphenous vein. The lesser saphenous vein is also involved in varicosities. Now, over here is a diagram which I made. This shows the great saphenous vein, which begins as a dorsal arch over here of the foot, goes in front of the medial malleus, goes just behind the, the knee joint, and then enters into the saphenofemoral junction over here, right? from where it joins with the femoral vein, and then it goes and forms the external iliac. Then again, the external iliac is joined by the internal iliac, and then finally it forms a common iliac and then inferior vena cava. Now, the varicose veins, by definition, is a dilated. Yes, just confirm. Are you audible? Am I audible, everybody? Yes. Yes. Yes.
Yes,
Yes, sir.
Yes, sir.
If
Yes,
anybody,
sir.
if anybody are audible at any time, please put a message.
Yes, sir.
Okay. So now,
Okay.
now this varicose. Now, along the way, there is a connection between the deep system and the superficial system. Please, right now, mute your audios. Everybody mute your audios. Everybody. So now there is a connection between the deep and the superficial system. Over here, around the ankle, there are two, what they are known as perforators, which connect the deep system and the superficial system. So there, around the ankle, there are two perforators. Then below knee perforator is over here. And then you have the mid-thigh perforator. Then where you have the main vein of the deep system, which connects over here, which is called the saphenofemoral junction. Now, varicosities, here is a picture I've shown you, a diagram I've shown you of a normal vein. This you have the valves of the vein. Now, as the blood moves forward, this vein, or rather this valve, opens out like this. Then your internet connection is unstable. When the blood tries to flow backward, the valve closes. But in the case of varicosities, because of the dilatation of the vein, the two leaves of the valves get widely separated and give rise to this incompetence. Right. I want to go back to my thing, to the video, the other thing. Yeah. I'll minimize. So where is the screen? My face. Yeah. So the varicosities, now this I like to tell students is one of the diseases of evolution. Why do you say so? Because man is the only animal who has chosen to walk on 2 feet. As a result of this walking on 2 feet, the heart has gone way up and the lower extremities have gone way down. In a 4-legged animal, the heart is almost at the heart, and the upper limb is almost at the same level, and the blood does not have to travel, venous blood does not have to travel such a long length. Now, as you know, the varicose veins, people with jobs where they have to stand for a long period of time, say for example a hairdresser, say for example a bus conductor, say for example a surgeon. Please mute your somebody. Can somebody mute your audio? Too much of disturbance come here. That's better. Everybody mute your audio, please. Yeah. Now as I was mentioning, that professions of, for example, even a surgeon would be more predisposed because of the prolonged standing. There may be prolonged standing, and of course, more important than standing without any movement, because the muscles of the lower limb act like a pump, pumping the blood upwards in upwards direction, and thereby that could give rise to stasis of blood around the lower limb, and then that could gradually give rise to dilatation of the lower limb and also and also varicosities. The veins become tortuous and dilated. Now, in addition to that, there may be incompetence. I had shown you the perforators earlier. There may be incompetence of the valves communicating from the deep system to the superficial system, in which case the valves on the perforators, they would cause a reflux of blood from the deep system onto the superficial system and thereby give rise to varicosities. Right. Now, the first thing of all is, now we will consider the most common clinical scenario where a patient comes to you in the OPD with varicose veins. And the clinical scenario would be like this. The patient would enter, you ask him what is his problem, he would say that swelling in the leg, most likely he would say swelling in the leg, and discomfort or pain. And he would point to his lower limb. The moment you look at his lower limb, you could make out the varicosity, very obvious. The other clinical presentation would be patient may present with a non-healing ulcer around the ankle. Now, if you ever have a non-healing ulcer around the ankle, you should think in terms of varicose veins. I can tell you a case of a doctor. He said that he came to me, his only presentation was that around his ankle, he had an ulcer which was refusing to heal. I said, definitely you must be having varicose veins. When I examined him, he had varicose veins, and the treatment was very simple. Ask him to elevate his leg, ask him to wear elastic stockings, etc., and it improved. Now, the patient so now when you take the history of the patient, presenting complaint, swelling over the lower limb, or pain over the calf during standing and relieved on lying down, then ulcer over the medial aspect, most commonly over the medial malleolus, which is non-healing. Third is eczematous or blackish pigmentation surrounding that or around the lower extremity, which is as a result of, that's another presentation. The third is that there is thickening of the skin in that region. Now, when you go to the history of the presenting complaint, the patient very commonly, sometimes what happens is that the patient would say initially he had some discomfort in the lower extremity, which increased when he was standing and decreased when he was lying down. Then by chance, he happened to injure, either he scratched his scratched the lower area, and that wound refused to heal. Where he had scratched, that became a big ulcer and just refused to heal. Now, third presentation is patient may just come with just blackish pigmentation over the lower extremity. So these are the three most common case scenarios. Number one is discomfort on standing, dilatation of the veins, of course, that will be there in all the cases, blackish pigmentation around the ankle. Third is that a non-healing ulcer. These would be the most common clinical scenario. Now, the history of the presenting complaint of the patient would be, you'd ask him, he would not give any particular, I don't think there's any sort of particular typical history which he would give. But yes, he would say that he noticed these dilated veins over here, it's been there for many years. Past, personal, family, etc. We won't go into, that's nothing very specific into that. But we go straight into the examination of this patient. Now, we won't go into general examination, we won't go into the systemic examination because it's not relevant to what we are talking about. We go straight into the examination of the extremity of the limb. Now, when you examine the limb, first is you examine in a standing up position. You will note that there are dilated and tortuous veins, which is very obvious. You would note the extent of the dilated and tortuous vein. Now, there could be various, not necessarily the entire great saphenous vein can be involved in the varicosity. It could be, say, a section, say maybe around the medial aspect of the thigh from the saphenofemoral junction to the mid-thigh, or it could be below the knee, the veins below the knee, or it could be around the ankle. So one is, you should note that where the varicosities are, the medial aspect or the lower extremity, mid-thigh, right? Next is that you ask the patient to lie down and you raise the patient's leg and you see that all the varicosities ideally should disappear completely. Then, as I had shown you, at the saphenofemoral junction, the femoral vein, which is a deep vein, joins the great saphenous vein and combines to form the external iliac vein. Now, at that point, if there's an incompetence of the valve present in the femoral vein, and in which case, if the patient coughs, there would be an impulse which could be seen over the saphenofemoral junction. You can see it. If you ask the patient to cough, you see a bulging at the saphenofemoral junction. This would indicate an incompetence at the saphenofemoral. What basically is happening is that the intra-abdominal pressure is increasing. And because of the increase in the intra-abdominal pressure, it is also causing pressure in the external iliac vein. And that causes blood to be pushed into the saphenofemoral junction and causing a bulging of the saphenofemoral junction, which would be seen externally. Right. Now, this is called Morrissey's test. Morrissey's test, where you see a cough impulse. Now, next is your examination of these varicose. Now, I have my years of teaching students. I know one thing, that students are more or less clueless of what they're supposed to do when they examine a patient with varicose veins. So first thing of all, you have to, when you examine a patient of varicose veins, basic thing you're examining is that varicose veins by itself is very obvious. If you look at it, you know it's varicose veins. Even a layman would tell you. But what you would like to know is whether there is any incompetence, or at what levels are the incompetence of the perforator, or if at all there are any incompetence of the perforator. So first thing of all is, as I mentioned, Morrissey's test. If it demonstrated a cough impulse, that could indicate a incompetence at saphenofemoral junction. Then there's Brody-Trendelenburg's test, in which there are two ways to make this do this test. One is that you put your thumb at the saphenofemoral, or you first, of course, before any of these tests, first thing is that you make the patient lie down, you raise the leg, you empty out the vein, then you apply your thumb at the saphenofemoral junction, and then make the patient stand up. Now, of course, one precondition I need to add into this is that there should be, in this case, there should be varicosities along the medial aspect of the thigh. Now, when the patient stands up and your pressure is there on the saphenofemoral junction, that is causing occlusion of the saphenofemoral junction. If the cause of the varicosities was as a result of a reflux from the saphenofemoral junction, then the varicosities would not appear. 1 minute, let me go to my sharing.
Share slides.
सामने आना चाहिए. इसको डिवाइड कर देता हूं. So, as I mentioned earlier, now over here, this is the saphenofemoral junction, and this is the femoral vein joining the great saphenous vein. We have put a thumb, or you could also use a tourniquet. That's another way to do a tourniquet. Now, as I mentioned, now the varicosity should be at this level. And if you keep your pressure over here, because if it is because of the reflux of the blood at the saphenofemoral junction backwards, because incompetence of the valve over here, you would see that there would be no varicosities appearing at this level. However, if this mid-thigh perforator in addition is also incompetent, you would see gradual filling of the varicosity from below above. Right? So when the pressure is applied over here, either with your thumb or with your tourniquet, you would not see this varicosity over here in the mid-thigh appearing. But if in addition a mid-thigh perforator is also incompetent, you would see a gradual filling from below upwards into the thigh. So that is one. The next thing is that the tourniquet test. Now in the tourniquet test, it is also called intelligent use of the tourniquet. You apply next again you empty and you apply a tourniquet over here, over the mid-thigh perforator, and ask the patient again to stand up. Now you would, if there were varicosities over here or below this level, if it was only due to the mid-thigh incompetence, these varicosities would not fill up. Right? Similarly, you apply it over here, and applying your tourniquet at multiple levels, you can demonstrate that they are incompetence of the perforators at the various levels. Let me repeat that again if I have not been clear. I have said one is that there is a great saphenous vein. You could have varicosities at various levels, say over here, or you could also have a varicosity all along the length of the great saphenous. Now, the perforators would be incompetent. That means a valve which connects the deep venous system to the superficial venous system are incompetent. Therefore, what does that do? That causes the blood to reflux from the deep system into the to the superficial system, that is the great saphenous vein, and thereby cause the varicosities to appear. Now, to just test at which level these are incompetent, what you have to do, you have to block the perforators. Block the perforators first at the saphenofemoral junction, then at the mid-thigh level, then below knee, around the ankles, and see whether if these perforators are implicated, then by blocking them, the varicosities below this level would not appear. Right? Below the level of the perforator, you would not see the varicosities appearing. Right? The next test is the Perthes test. Now, Perthes test is you take a crepe bandage and you apply it completely over the limb right up to the saphenofemoral junction. Now, what does the crepe bandage do? Crepe bandage causes the veins to collapse, saphenous vein to collapse. It also occludes the perforators, and then you ask the patient to walk. Now, when the patient walks and if the deep system is there is deep venous thrombosis, is not patent, then the patient will experience a bursting sensation, meaning that the blood is attempting to be pumped up, but is not able to climb up. So he will feel like the limb is bursting. It's described as a bursting sensation of the limb. Another way, which it can also be demonstrated, rather than using the crepe bandage, you use multiple tourniquet and apply them at the perforator level, at the saphenofemoral junction, mid-thigh, below knee, around the ankle. And again, the same Perthes test could be demonstrated. Now then there is Schwartz test. Schwartz test is because there are all these valves all along the length of the great saphenous vein is incompetent. If you tap the vein, say around the medial malleolus, that same impulse will travel upwards and you will feel it up here, say around the saphenofemoral junction. So that is called a Schwartz test. Then there is Fagan's method of demonstrating the perforators. Fagan's method, I mean, all in this case, now this is, you want to know the position of the perforator. So in Fagan's method, what you do is you palpate the great saphenous vein, and wherever there's a perforator, you can feel the defect in the deep fascia, where the perforator goes and connects to the, or where the perforator comes out from the deep system in the superficial. So you'll feel gaps or other defects in the, this, I mean, this can only be felt with experience, and then you can say, okay, the mid-thigh perforator is this level, below knee is over here, around the ankle is over here. So we have slightly jumped straight to the test. I would just go back to how systematically you should examine the patient. First is inspection. Your inspection would say that dilated and tortuous veins. You would mention the extent of it, say you only around the medial aspect of the thigh, below the knee, around the ankle. Next is whether there's presentation, whether you see any pigmentation around the ankle, whether there's presence of any ulceration, right? Then that would be your inspection. That only thing you would be doing is to see. Then of course, yes, one more thing in the inspection is your Morris's test. You'd also you ask the patient to cough, and you would see the impulse at the saphenofemoral junction. So this much you can do by inspecting the patient. Next is palpation. Palpation would include your Brody-Tenenberg test, your tourniquet test, your Perthes test, your Schwartz test, your Pratt's test, and your Fagan's method of. So all these tests, what are they doing is, except for Fagan's, they are demonstrating the incompetence of the perforator. Right? Now, the question may arise in your mind that what is the importance of the incompetence of this, or demonstrating the incompetence of this perforator. There was one case which I treated. Was he only by demonstrating he only had varicosities below the knee, around the medial side of the lower limb, and by occluding the below knee perforator, I could demonstrate there was no appearance of varicosity. Plus, he had a chronic ulcer around the ankle joint, which refused to heal. So his treatment, rather than subjecting him to a very major treatment, all I did was I made under local anesthesia, I made a small cut over here, and I ligated the perforator, below knee perforator, and the ulcer healed and he improved. And subsequently, he started working for me also. He's now presently my guard. So I review him almost every day, and he's perfectly all right. Now, what could the complications of varicose veins be? Number one is you could get a hemorrhage. There could be a torrential hemorrhage as a result of varicose veins, because these veins are very superficially placed. Say, for example, as a result of some very minor trauma, the vein could get injured and the veins lie very superficially and then bleed. If you're faced with such a situation where a patient comes with massive torrential bleed, and very frequently patients come like that, first thing you do is you make the patient lie down. Second thing you do is raise the patient's limb, allowing the venous blood, which is pooled around the varicose veins, to drain. And second thing is you apply a tight bandage over the point from where it's bleeding. This is the method you'd follow to stop the bleeding. Now, phlebitis, there could be inflammation of the veins. There could be calcification, which could be felt also. Then, as I mentioned earlier, there could be ulcerations. The ulcerations are as a result of, because now what is happening is, because of the chronic stasis of the blood, there is the blood is sort of pooling around the ankle. The blood extravasates into the surrounding tissue. Once it extravasates, the hemoglobin of blood is converted into hemosiderin. This hemosiderin then is black, and it causes the pigmentation of the eczematous changes over there and causing a weakening of the skin, so therefore could give rise to ulceration. Then, because of this chronic stasis of the blood, I want to the screen share only. Just keep it on the screen share. Slideshow.
Slideshow is background on this. Background is slideshow on this.
But I want to use it for this. So now, because of the stasis of blood, again, there's supposed to be deposition of fibrin around the capillaries, and this gives rise to thickening of the interstitial tissue and the skin, giving rise to a thickening of the skin, which is classically called as lipodermatosclerosis. Right. Then, of course, because of the chronic dilatation of the vein, there is what is called as periostitis, or there is inflammation of the periosteum. And because the patient experiences relief by keeping his foot in a sort of what you call it, or plantar flexation of his foot, there is a condition it develops which is called an equinus deformity. Equinus means horse, and the foot then begins to resemble a horse. Okay. Now, the next, what I would let me summarize once again. We have a patient, varicosities of the great saphenous vein. We inspect the patient. Inspection, we first describe the varicosities, now where the varicosities are present, whether lower part of the leg, around the ankle, medial aspect of thigh, further up. Okay. After that, next is we mention whether there are any ulcerations or not, whether there is any pigmentation, eczematous changes or not. Third is whether there's any thickening of the skin, which is lipodermatosclerosis, right? So that's much inspection. Then palpation, as I mentioned, we subject the patient to all those tests where we can demonstrate the incompetence of the saphenofemoral junction or the perforators at the various levels. The third, as I mentioned, the Fagan's test or Fagan's method of palpation, we would palpate the defects in the deep fascia where we know, where we can localize that this is the point where the perforators are. Now, finally, we come to the treatment. Now, what is the treatment of the what is the treatment of varicose veins? Now, here is the methods of treatment. I hope everybody can see it on their screen. The first treatment would be the easiest and which we follow very frequently, is what is called as stripping. Stripping means basically removing the entire great saphenous vein. So henceforth, once you have removed the entire great saphenous vein, you will not have the great saphenous vein. All the varicosities will also come out with this, and therefore you would not have the problem associated with the great saphenous vein. Now, the stripping is done by using a stripper. Stripper consists of this part. This is the handle of the stripper. This is a long wire, and it has spirals at both ends. On one end, you could fit this handle. The other end, you could fit these various attachments. Either this tubular attachment, which is useful for passing it through and this other attachment. What you do in a stripping is first in the stripping, what you do is you do what is called a Trendelenburg's operation, where you make a cut you make a cut at the saphenofemoral junction. You expose the saphenofemoral junction. You ligate the saphenofemoral junction, means you ligate the attachment of the femoral vein to the great saphenous vein, and you isolate the saphenous vein. Then next is you make a cut over here in front of the medial malleus, identify the great saphenous vein over here, and then using this, you pass this and you thread it through the entire length of the great saphenous vein, and then you put this bigger attachment over here and you pull it. That will avulse the great saphenous vein entire length along its attachments. The other one is either radio frequency ablation or laser ablation. This is in a sense quite similar to that. You destroy the great saphenous vein by passing another probe along its length, which may contain either an energy source at the tip, which could be either a microwave, that is radio frequency, or a laser, and you keep on passing it along the length of the great saphenous vein and firing. So as you pass it, you fire it, it burns the great saphenous vein and thereby destroys it. Right. Then there is subfacial ligation of the perforator. Now this, as I told you about the previous case I told you, where you could identify that the cause of the varicosities are due to limited perforator incompetence. Then all you need to do is just ligate that perforator. Or you could, if there are multiple perforators, you could ligate multiple perforators. So one is that you identify the perforator which is incompetent, you ligate it. You have to be sure that the cause of the varicosities are only because of the reflux from this perforator. There's one more way to also do it, is what is called a sclerotherapy. In sclerotherapy, you take a syringe which contains a substance which causes a sterile inflammation, and this sterile inflammation causes the perforator to get sclerosed or thrombosed, and thereby obliterating this perforator. So sclerotherapy or subfacial ligation. Now there is also another method called SEPS, subfacial endoscopic perforator surgery. In this, what is done is that you make an incision over here around the near the medial malleus, and under the skin or you make it till the deep fascia, and then you pass a scope under the deep fascia, and you will see these perforators as you go past the scope along the great septum. You see these perforators which you will ligate as you go up. Now this is not possible. It's possible up till the below knee perforators, but it's not possible in the thigh, because thigh tends to be very thick, the fat, etc. So it's not possible at the level of the thigh. So this, one more thing which I did not mention is, of course, conservative management of varicose veins. Conservative management consists of that elastocrepe bandage, where elastocrepe bandage, the function, as I said earlier, what it does is compresses the veins, obliterates the perforator, so therefore keeps the. Now this should be applied when the patient is standing and walking. In the night it should be removed. Second is elastic stockings, which also are more easier to apply than an elastocrepe bandage. Third is in the case of ulcers, where the patient is advised rest, raising of the limb, etc. So basically, these are the conservative methods by which we can treat the patient. Right now, so I would, anybody has any questions, or can you give it back to the front screen? Anybody has any questions, please ask right now. Anything you want to be elaborated?
They can raise their hand, unmute themselves, and ask the question.
You raise your hands, unmute yourself, and ask the question. Anybody? Everybody's understood everything?
Announcement करूँगा इसमें अगर टाइम
Time है कितना, how much time will take?
ये सब भी extend हुई है.
Nobody? Somebody? Unmute yourself and ask the questions, please.
Sir, apart from the clinical tests that we do we have any other examinations or any other investigations rather that we do?
See, the most important investigation is Doppler study of the lower extremity. Now that would tell you, I actually, as a matter of fact, I tell students that these days, because of these, there's no, actually, ideally, there's no need to do all these tests which I told you. Because once you do a Doppler that accurately visualizes all the incompetent perforator, this, that, the other, so that you require no sort of clinical acumen whatsoever. But then since you're a medical student, you're expected to know the clinical examination. Otherwise, it is very easy for us. We have a patient of varicose veins. We don't have to do any clinical examination whatsoever. Send him for Doppler.
Paused.
Yes. Send him for Doppler.
No, sir,
Yes.
You weren't audible. Now you are audible. Please continue.
Yeah, did you hear the earlier part of what I said? Till what point did you?
No, sir.
No,
No, sir.
What I was saying is that the simplest or the only relevant test. Now, one more thing is there now, which I also emphasize to students, that when you're asked a management of a patient, you should mention the test which establishes your diagnosis. So now you have a varicose veins and you want a test to establish. Now what happens normally, student tends to say CBC, blood urea, creatinine, all that. That's got no relevance to this particular thing. You will do that for assessment of the patient, but you won't do it for establishing your diagnosis. How do you establish your diagnosis? By doing a Doppler. Doppler study, you can accurately find out the flow of the venous flow, by which it will monitor that, okay, where the perforator incompetence lies, septo-femoral junction incompetence, deep system competent or incompetent. So what I was repeating again is, ideally you don't need to do any of these clinical tests. You straight away send him for a Doppler, you will get all the answers which you require. But then because you're a student and for better understanding of the disease, it's important to know these tests. Does that answer your question?
Yes, sir. Thank you.
What is the treatment of varicose vein with DVT?
Okay. Now, I think Mr. Vineet has asked, what is the treatment of varicose veins with DVT? Stripping cannot be. Now, that is a very good question. In DVT, yes, we cannot do. One more thing which I failed to mention or did not mention is that if a patient has DVT, you cannot do a stripping. Why? Because the superficial system is the only system by which the blood is draining back into this. And if you remove that, then the patient will get a dangerous congestion of the lower limb. So ideally, there is no treatment, in which case you cannot do anything about the patient. The patient has to learn to live with his varicosities.
What about drainage after stripping? Shubham has asked.
Yes, Shubham has asked what is about drainage after stripping. Now, after stripping, the venous blood drains via the deep system. That is what again, which I mentioned, which I said, before you do a stripping, you have to establish that the deep system is totally intact. There's no deep vein thrombosis. So once you've done the stripping, the deep venous system takes care of all the drainage of the blood, because unlike the arterial system, the venous system has got multiple anastomotic channels. So then even the smaller anastomotic channels dilate and take over the drainage. Then, Shrusti, sir, could you explain the fibrin and thickening of skin? As I mentioned earlier, we have what is called as stagnation of the blood, especially in the areas where there's maximum gravity around the ankles, etc., or lower extremity. Now, the blood is not going out, or neither it is, rather the blood is not going up draining, and it is just lying, pooling over there. Now, because of that, it creates additional pressures in the capillaries, causing increased fibrin deposition around the capillaries. Basically, I think this mechanism is there to strengthen the capillaries which are facing more intense pressure. And this in itself, fibrin, would cause fibrosis and in thickening of the skin surrounding it, which is classically called as dermatosclerosis. Okay. Any other questions? Any other questions? Anybody has any other questions? Okay, then I will hand over the mic to Dr. Vasnik, HOD. He can.
Hello students, are you getting me? Hello?
Maybe your CR can unmute his mic. Shubham can unmute his mic.
Hello? Shubham, are you getting me?
Yes, sir.
Good afternoon to you all. I hope
Hello.
you enjoyed the lecture by Wilkinson sir. I want to make the announcement that tomorrow I'll be taking your class at 12:30. Abdominal examination Topic will be abdominal examination.
Hey, please, everybody mute your mic now, please.
Okay, I'm getting your messages. I'm happy you're responding. Okay. So tomorrow at 12:30 sharp, we'll be starting lecture series on abdominal examination, and if time permits, we'll discuss pseudocyst of the pancreas. We have got one case. Already we are very short of cases, but luckily before operation I could catch hold of the patient and take some videos of the abdominal examination. So hope that will help. So at 12:30. So today we stop the session here. Hope to see you tomorrow at 12:30. Bye bye.
Recording.
We recorded.